All right, we're live.
All right, thank you. And good morning, everyone. This is the Senate Health and Welfare Committee, and it is January 27th. This morning, we're going to take some time to learn a little bit about, probably a lot, about our healthcare reform efforts. And so we're very honored and pleased to have Ina Backus with us, who is the Director of Healthcare Reform within the Agency of Human Services in the Secretary's Office. So Ina, welcome. And I think, well, I'll just turn it over to you. I think you know everyone on the committee, so we don't need to go further with introductions. So, okay.
Thank you.
And thanks for being here.
Good morning. For the record, my name is Ina Backus. I'm the Director of Healthcare Reform in the Agency of Human Services. I am going to attempt to share my screen now. It appears that I'm successfully sharing my screen. Please let me know if you're not able to see.
You're good. If there's a way that you can put it on slideshow, then it will, yeah, you're doing it. That's good. Thanks.
Great. So I wanted to begin our conversation this session with laying some groundwork regarding healthcare reform in Vermont. And in order to do that, I talked with Chair Lyons and thought it would be helpful to provide some introduction and brief history of healthcare reform in Vermont up to this point, and then to focus on the Vermont All-Payer Accountable Care Organization Model Agreement, which is one of the key healthcare reform initiatives that is currently underway in the state today. However, as you'll see as we talk through some of the healthcare reform history for our state, the all-payer model is certainly building on previous reforms that are still active and in place today, and is complementary with other healthcare system reforms that we have in our state. So it's not the only aspect of healthcare reform, although it is a primary healthcare reform initiative at this time. I like to ground a healthcare reform conversation in thinking about the healthcare system for our United States, because Vermont is certainly a part of a union and is impacted and is not immune from the healthcare system that we have for our United States. And we have a important state and federal relationship that certainly informs how we approach healthcare in the state of Vermont. I just highlight that we are a part of a nation that spends more money on healthcare than any other country in the world. And yet, despite spending more than any other country in the world, our life expectancy in the United States is not necessarily as good as other developed nations. And in fact, we trail other developed nations in our life expectancy in the United States, in spite of our healthcare costs being considerably more than those costs in some other developed nations. And we see the impact in particular on life expectancy of deaths due to suicide, drug overdose, and alcohol-related deaths in our country. In Vermont, our healthcare system, it in some important ways mirrors the healthcare system in the United States, in that it is a large and complex system, and spending on our healthcare system in our state is considerable. The healthcare spending on behalf of Vermont residents for the most recent year that we have data was $6.3 billion. And you can orient yourself to that spending in thinking about what the overall budget is for our entire state of Vermont. healthcare spending as a share of gross state product in our state was, I can't quite see myself. It's around 18%. I can't see the exact amount because of the way the screen is oriented. I hope you can. And we do know that health outcomes for Vermonters can be improved, and we have particular room for improvement in some key areas: chronic disease, prevalence and morbidity, health outcomes associated with substance use, alcohol use, and certainly we have deaths due to suicide in our state that are more than the national average.
Ina, I'm not going to interrupt you through your presentation, but can you comment briefly on what is included in your healthcare, the definition of healthcare that you have there? Does that include substance use disorder counseling and treatment, mental health counseling and treatment? How extensive? Does it include everything that's in our Medicaid waiver, I guess is another way of.
Yes, that's a great question. And yes, this is a pretty expansive definition of healthcare spending on behalf of Vermont residents. It is a definition that can be aligned with how we look at healthcare spending, or healthcare spending is evaluated for other states. The Green Mountain Care Board annually conducts the health expenditure analysis, and it's the Green Mountain Care Board's data here that is depicted. The spending, it is inclusive of our Medicaid program. It is inclusive of healthcare expenditures on behalf of Vermonters, and that means spending for mental health, substance use disorder treatment, and services that are beyond what we would consider to be just hospital and physician services. Yes, it is more broad. It includes home and community-based services, long-term services and supports as well. When we talk about healthcare reform and the system of healthcare, there are many different problems that we could be trying to solve, because as I've just described, the system is large, it is a complex system, and it is certainly a system that is intertwined with our economy in a number of different ways. So in thinking about our healthcare system and health reform initiatives, it is helpful to ground these initiatives in a few questions regarding the problems that we're trying to solve. There are problems of healthcare financing, meaning how the money is collected for paying for healthcare. Then there are issues regarding healthcare coverage. Who has access to coverage? What restrictions are there on healthcare coverage? Are there discriminatory policies associated with healthcare coverage? And we will, as we dive into some history of healthcare reform initiatives in the state, I'll talk about how some of these problems have been answered by initiatives in our state up to this point. There's also the problem of healthcare spending growth. When we think about whether healthcare is affordable, what are the issues that are driving healthcare spending growth? Is how we pay for healthcare driving healthcare spending growth? And that's a key question that comes into consideration with our all-payer agreement healthcare reform initiative. And then healthcare delivery and the quality of care we receive. How is healthcare being delivered to be efficient? Is healthcare being delivered in the lowest costs and most appropriate settings? Are the quality of services that individuals are receiving as high as they can possibly be? Is the quality of experience in the healthcare system as good as it can possibly be, can Vermonters have meaningful relationships with their primary care and other providers? And importantly, are providers accessible to Vermonters? And all of these types of issues are very much at play in the work that we are doing in terms of payment and delivery system reform at this time. However, we have worked on these problems iteratively over time. And now I'll take you through this chart, which I realize there's a lot here on the page, but I do want to try to cover some ground and talk about how these reforms over time in our state have addressed different problems for the healthcare system. And then I also want to point you towards the way national reforms kind of intersect with some of the initiatives that Vermont has taken on, and how Vermont's initiatives have actually come into play in national reforms, sometimes much, much later on. And so I'll point that out to you as we go through. In 1989, Vermont created the Dr. Dinosaur program, which utilized Medicaid program to increase coverage specifically for pregnant women and children, recognizing how important prenatal and early child care are for long-term health and well-being of our people. That program, as an example, was both a financing problem. How do we pay for coverage for children and pregnant women and children? And it's also a coverage question. There were key populations for whom healthcare coverage was not as accessible as it should have been to address the health needs of a population. In 1992, Vermont undertook a small group and individual health insurance marketplace reforms that included guaranteed issue, meaning that persons wouldn't be denied healthcare coverage due to pre-existing or due to changes in status, as well as Vermont undertook community rating so that healthcare premiums would be relatively the same regardless of age and regardless of group. And that was a coverage initiative at that time. And then we see later on, so this is 1992, skip ahead to 2010, and the Affordable Care Act gets around to taking on some of these same issues in national health policy. In 1992, we saw hospital budget oversight and certificate of need law come into play, where regulatory authorities would be looking at whether or not healthcare services that would be implemented in the state, or healthcare facilities being created in the state met the criteria for a certificate of need. And this is really looking at this concept of if you build it, they will come. If you build more healthcare facilities, then you will see more healthcare utilization. And there are two sides of that coin. That can be a very important aspect of the system, ensuring that there's access for Vermonters to needed services. And at the same time, the certificate of need process allows there to be an assessment of whether or not the services are indeed needed and necessary. And along with hospital budget oversight, that's a regulatory process which now takes its shape in the Green Mountain Care Board in order to provide oversight for healthcare spending in hospitals. So that's a spending approach. It's an approach to a spending problem in healthcare reform. The Vermont Health Access Program, that was in 1995 implemented through a Section 1115 Medicaid waiver to cover low income and childless adults. The problem that this program is trying to solve is both one of financing and coverage for certain groups. And again, 1995, we go ahead and make this healthcare reform happen in Vermont, and then see later on 2010 through the Affordable Care Act that comes to be a federal policy for expanding access for childless adults. In 2005, the Choices for Care 1115 waiver allowed there to be continued coverage for community-based long-term services and supports, so that Vermonters could receive services and supports in their homes and not necessarily need to receive those services and supports only in an institution or a facility. And that's addressing both the coverage and the delivery system issue. In 2006, the Global Commitment Waiver, which is an 1115 waiver, created the Catamount for Health program, which was a subsidy program for individuals to purchase private insurance, and created a program for individuals who to access private insurance through the marketplace. That was both a financing and coverage problem that the Catamount for Health program was addressing, and that the ACA adopted subsidies for private insurance, and we have those in place today in Vermont. The delivery systems reforms also created through the Blueprint for Health happened in 2006, and we still have in place today the Blueprint for Health, and we'll talk quite a lot about how that's a foundation for delivery system reforms that are happening today and being supported by additional payment reform activities. In 2011, Act 48 created a publicly financed universal health care program, which was to be implemented only after the General Assembly enacted a law to finance the program. But Act 48 also created the Green Mountain Care Board to reduce the rate of growth in health expenditures and improve quality, and at that time created the Health Benefit Exchange in anticipation and in alignment with the Affordable Care Act, which provided for the subsidy program for the purchase of private insurance. In 2013, the Blueprint, along with the Department of Health, created the hub and spoke model for medication-assisted treatment for persons in recovery from opioid use disorder. And this is a delivery system reform models, creating a delivery system to meet the needs of and to be responsive to the needs of individuals in recovery from opioid use disorder, and particularly those who are seeking medication-assisted treatment in a variety of different and appropriate settings. In 2016, Act 113 allowed the Green Mountain Care Board and the Agency of Administration to enter into an agreement with CMS to implement an all-payer model. And this is an approach to address healthcare spending growth, and also to improve healthcare quality and to improve the delivery of healthcare. The legislation defined an accountable care organization and directed the Green Mountain Care Board to adopt ACO standards and budget review criteria. I think you'll hear more about that from the Green Mountain Care Board. And it required the Agency of Human Services to establish a process for integrating Medicaid providers and services into payment and delivery system reform. And finally, in 2019, Act 63 established an enshrined in Vermont law some consumer protections that were provided for through the Affordable Care Act, and it maintained those in Vermont law in the instance that the Affordable Care Act certainly coming under fire would be compromised. And so that those particular protections speak to healthcare coverage and the accessibility of healthcare coverage for Vermonters.
Ina, let's take a pause right here. And I have just a couple of questions, and I think others may as well. And if they don't, fine. And if we do, maybe you could just give some brief answers. Can you briefly tell us what the health benefit exchange is?
Yes, the the Affordable Care Act provided for pretty groundbreaking and sweeping policy change to allow there to be a federal program of subsidies available to individuals that are looking to purchase healthcare insurance coverage. And those subsidies are available for individuals up to 400% FPL. The exchange is also a place in Vermont for small business to purchase healthcare coverage. It's a regulated marketplace that can be, states had choice to operate that regulated marketplace as a state or to use the federal exchange, if you will. The regulated marketplace provides both for a place for consumers to comparison shop in terms of plans, and the plans have essential health benefits, and they are benchmarked and comparable across different levels of coverage. Consumers can use this regulated marketplace to compare and shop for plans, and then those consumers who are within the guidelines for the federal poverty level, under 400%, again, there is a subsidy in place in the form of advanced premium tax credits from the federal government. And certainly, if you want to do a deep dive on the exchange and to understand that model, I would arrange for my partners at the Department of Vermont Health Access to do that with you if that's of interest.
I think for today that's sufficient, and if we get there, we may do a deeper dive. The other thing, there are a couple of things that obviously are not in the list, but for example, the work that we've done on transparency of pricing and cost, the prescription drug importation that you're going to mention later, and then the other one is the HRAP, the Health Resource Allocation Plan, which is done at the Green Mountain Care Board. Maybe just a brief comment about HRAP, if you can. You don't have to.
I absolutely can give you just a brief comment on it, and then again would encourage the Green Mountain Care Board if you're interested in doing a deep dive on that topic. But the Health Resource Allocation Plan is intended as an assessment to understand what the healthcare resources are across the state and their availability to Vermonters, and where there is adequacy of resources and or a dearth of resources, and I think is particularly important when looking at the geographic nature of accessibility in our state.
Yes, and we have, I believe that one of the reports that we have coming in will have some updates on geographic availability of services and how to integrate services geographically. But anyway, that's good. Thank you. Questions, committee, on all of this? Senator Hooker.
Thank you, Madam Chair. Ina, the health benefits exchange is open to individuals as well as businesses and groups. So
that's
an
correct.
individual can get coverage. Okay.
Absolutely. And the exchange and the health benefit exchange is in particular intended to meet the needs of those individuals that aren't offered coverage through their employers and yet should have access to reasonable cost of coverage. And so that was intending to meet that need for individuals in particular.
Thank you.
So this is, I guess this is where you hear about silver and platinum and gold and bronze plans. Right. Okay.
I just remember a time when it was difficult for individuals to purchase insurance, and I'm glad to see that there's an option for them.
Absolutely. And in Vermont, we did work to address the difficulty for individuals to purchase insurance. We did that initially through the Catamount Health Program. And then with the Affordable Care Act coming into play after 2011, Vermont implemented the health benefit exchange to be in alignment with the Affordable Care Act and to maximize all of what was available through the Affordable Care Act in terms of considerable additional federal participation in subsidies for individuals, whereas previously Vermont had managed that program in part through its 1115 Medicaid waiver and investing in those subsidies. So we were poised, I think, to be able to align with the federal program and to adopt the requirements of the federal health benefit exchange. And I definitely should have prefaced this as being a few highlights and illustrative examples of healthcare reform initiatives in our state, by no means an exhaustive list, and should not be taken as such, simply a way to describe over time some of our healthcare reform initiatives and the different problems in our healthcare system that they were trying to address. So I want to transition now, unless there are further questions about the list. Transition now to the current healthcare reform initiative that is underway, that is called the All-Payer Accountable Care Organization Model Agreement, and talk a little bit about how that agreement has come to be, the evolution of our work on cost containment in the state of Vermont, how that cost containment work came to be reflected in the All-Payer Accountable Care Organization Model Agreement, and some of the foundations for it. I wanted to share this slide because this is actually a slide that is from 2013. So it's getting old now, you could say, but it is also incredibly relevant and does describe the path that I think we have been on to intentionally move the state away from a fee-for-service system of reimbursement for healthcare providers. So I briefly said in my introduction that spending on healthcare and healthcare cost growth is a particular problem that the system is confronting, and that to address that problem, we can think about how we pay for healthcare and whether or not paying for healthcare differently can impact on that spending growth that we've seen in our system that's been pretty exponential. And so here in our 2013, we articulate that we want to move away from fee-for-service reimbursement because the way that we're paying for healthcare, and I will elaborate on this in the next slide, is contributing to cost growth in healthcare. And in order to move away from fee-for-service, we would certainly want to build on the platform of the Blueprint for Health, which is a strong primary care system that is supported by community health teams that are expert in coordinating care across different settings. So emphasizing prevention, health promotion. And in order to be successful in reform, a key principle also includes that the reform include all payers. And what do we mean by that? There are multiple payers in Vermont and in the United States healthcare system. There are public payers and there are private payers. We have three major payer types in the state of Vermont: the Medicaid program, which has historically been the payer for persons with low income; the Medicare program, which provides coverage for persons 65 and over; and then we have the commercial coverage, which is offered through employers and is also offered through the health benefit exchange. In order for the system to be able to respond to a change in payment, it's important that all of those major payer groups are participating in that payment change so that it is consistent for the system, and so that the expectations are aligned across the payers. The healthcare system in the United States is complicated because there are multiple payer types and there are multiple rules and there for payer types. And in Vermont, it's been important to emphasize alignment across those different payer types as much as possible. And finally, to ensure that we are moving in the right direction in improving quality and patient experience of care, we need in our reforms to have performance measures that capture our goals for improvement and that allow us to measure whether or not we are meeting those goals incrementally. Now to talk more about that payment change in terms of addressing healthcare spending growth. The predominant way that healthcare has been paid for in the United States for a very long period of time, but becoming especially predominant with the Medicare program being implemented in 1965, is a fee-for-service reimbursement model. And the fee-for-service reimbursement model simply means that for each and every service that's performed in the system, there is a payment for that service if it is a covered service. Now, some really important services in our healthcare system, such as time spent coordinating with other providers, making phone calls, communicating with patients and or the care team, those types of services are actually not covered in the fee-for-service system and yet are very important for improving care, improving outcomes, and providing a good experience. So the fee-for-service system is paying for covered billable services, pays for each and every service regardless of the outcome, and therefore there's an incentive for the system to do more and more of those types of services. And I want to be very clear that the system is incentivized and not necessarily particular providers that are just doing more and more, but the system overall is essentially rewarded if there are redundant services or if there are services that may not be in the least cost, most appropriate setting. And so if we think about changing payment as a way to curb healthcare cost growth, moderate healthcare spending, then we think about setting a budget for the healthcare system instead of paying for each service. And this setting of the budget allows for two things. It's a budget instead of a time, and it's a budget, and within that budget there is more flexibility for providers to do those things that contribute to high quality patient care that may not be paid for in the traditional system. And this budget can be tied to the quality of care that is delivered for patients, and it can be tied to health outcomes. Because the first question that comes to mind for people is, well, if you're not going to be paying for each and every service, then am I not going to receive services that I need? And is the budget going to lead providers to not to prescribe or to deliver services because they're going to be doing better living in the budget, not doing these things? And the answer to that is that if the budget is tied to clear metrics for improved health outcomes and the quality of care that we expect the system to deliver, then that acts as a governor, if you will, on that behavior. So I'm I can't quite hear myself talking, even though I think you can hear me a lot better when I'm wearing that headset. I sound like I'm in my own head. This is much better.
Well, go right ahead and we can hear you. If there's a problem, if you can see me, I'll just wave my hand.
Okay, I can see you. Thank you.
Okay, good.
So there's a logic model that's driving the change in the healthcare payment and delivery system that we're trying to achieve, in particular through the all-payer accountable care organization model agreement. We want to test these payment changes to determine whether if we pay differently for healthcare, and specifically if we move away from fee-for-service and we invest more in primary care and prevention, whether or not those investments and those changes have an impact on improved population health outcomes. And we also know that if we pay differently and if we provide for a clear, predictable budget for the system, that the system can then incorporate perhaps services and supports, and like I said, activities such as care coordination that otherwise wouldn't be necessarily emphasized in our fee-for-service system today. So when we see those things incorporated, do those then have an impact on our population health outcomes, and specifically improved access to primary care, fewer deaths due to suicide and drug overdose, and a reduced prevalence of morbidity and chronic disease? So you hear this term, the Vermont All-Payer Accountable Care Organization Agreement, and why do we have an agreement with the federal government? And that gets back to the need for a change of this kind to be aligned across the different major payer types in order for the change to make sense to those who are delivering the care. It's important that it be consistent. And Medicare is the federal coverage program for older residents and older Vermonters. And Medicare is not governed by the state of Vermont. It's a fully federal program. Our Medicaid program is a partnership between the state and the federal government. And again, Medicare is purely a federal program. So in order for Medicare to participate in Vermont in a reform project, we need to have an agreement with the federal government for Medicare to basically work with the state and to adapt its model to Vermont's terms. And so our agreement with the federal government enables Medicare to join with our Medicaid program and commercial payers in our state in aligning a payment model
for accountable care organizations. And we'll talk about that straight away in the next slide, to pay accountable care organizations differently than fee for service. So accountable care organizations are key here. The federal government and Medicare as a partner said, we will agree to work with Vermont on Vermont's terms to pay an accountable care organization differently than fee for service. Medicare will not pay just any one provider in the state of Vermont differently than fee for service. Medicare in our model is paying accountable care organizations differently. Accountable care organizations are composed of and led by healthcare providers who agree to be accountable for the cost and quality of care for a defined population. And these providers share governance structure, and they work together to provide coordinated, comprehensive care for their patients. There are a few key benefits of accountable care organizations, and I think you'll hear more about this if you hear from One Care Vermont. We do just have one accountable care organization in the state of Vermont. It is called One Care Vermont, and it is a network of providers that are working statewide together to do exactly what's articulated here, to coordinate care and provide comprehensive care for patients for whom they are accountable. And One Care Vermont is able to accept these alternative payments, both from the federal government as well as the state of Vermont's Medicaid program. And you'll hear more about that, I believe, as well, in detail, as well as commercial payers. One Care Vermont contracts with commercial payers to enter into fee-for-service alternative agreements. So overarching, we have an agreement with the federal government that says the federal government will join in paying a network of providers in our state that are working together differently. And that network is also able to share any savings that the network creates by being successful under this alternative payment methodology. Then the ACO works with payers and develops ACO level contracts and agreements. And then the ACO provides provider level agreements with its network of participating providers to deliver care and to be paid differently.
Ina,
Yes.
before you scoot ahead, just going there and just hold for a second. So what we are hearing you say is that our model in our state, based on all the work that we've done, is a primary care prevention model that integrates social services and attempts to reduce the effect of social determinants of health. So overall, looking at the patient and how to keep the patient healthy. When a provider keeps the patient healthy, then one might assume that there is less cost for that patient. So the healthier populations then result in savings within the system. And those are the savings that we might see and benefit from, or the ACO might benefit from. But it doesn't change, this model doesn't change access to care. It actually may improve access to care for patients. So I'm just trying to move it to more of the kind of the practical level. What does it mean for me when I walk in the physician's office or the healthcare office?
Absolutely.
Yeah. And
Yes.
go ahead. And that the provider is paid in a way that allows the provider to feel compensated for the phone call that the provider makes to patients or answers questions over the phone or the internet. So that kind of thing.
That's absolutely correct. Again, going back to what problem are you trying to solve? This model is chiefly trying to solve the problem of moderating healthcare cost growth and improving healthcare quality and outcomes in our state. It is not a model of coverage. A Vermonter would not seek to be covered by the Accountable Care Organization for its insurance. You would not sign up with the Accountable Care Organization even as a provider. It is an organization that is made up of healthcare providers that are choosing to participate. They may be your healthcare providers. There are many providers that are a part of the ACO network, so it's highly likely a provider of yours could be in the network. But again, that's absolutely right. It's a way that the system is being paid and is delivering care differently. It is not a coverage option for a Vermonter.
Do you want any other questions at this point, or should we move ahead? Does anybody have questions?
Yes, Senator Lyons, I have a question.
All right, go ahead.
Ina, I know that the ACO model is not, or the all-payer model does not actually have everybody in it at this point. So if, for example, I have private insurance through my spouse's employer and they are not participating in the ACO, what does all of this mean for the fact that we don't have actually very much participation in the ACO, or as much as we had hoped or wanted?
We have very aggressive targets. Here I can talk about the targets. The targets for our agreement are aggressive. The all-payer model agreement is intended to be a statewide agreement, and it's intended that way so that providers have a strong incentive to adjust their business models, just like we've been talking about. We do know that those targets do not necessarily appreciate all of the dynamics in the Vermont landscape in terms of who can actually be attributed to an accountable care organization. For instance, the accountable care organization model, for the most part, a person is attributed based on two factors. And Senator Hardy, you just named one. First, that your coverage needs to be participating with the ACO. And so not all Vermonters healthcare coverage does participate through contract with One Care Vermont. We have an implementation improvement plan, which we can cover in more detail at another time, certainly, where we acknowledge that we have more work to do to educate non-participating commercial coverage providers about the benefits of participating in a model of this kind. So we have progress that we need to make. We know that the model will be most effective if it's aligned across as many payers and providers as possible. So payers have to be participating, and then to be attributed to the ACO as part of your care being provided for through the budget. You also have to have your primary, for the most part, your primary care provider needs to be a participant in the ACO. And it is also the case that there is more progress to be made with participants, although there is quite broad participation through a statewide network, and we are seeing some increased participation in the Medicare program in particular for 2021. And we can talk, I'd be happy to go talk about definitely to elaborate on our performance to date in this model, and based on that assessment of our performance to date, where we think we need to make some strategic gains.
Why, I think that's a deeper dive. Why don't we
Yep.
save that? Because we will hear from the ACO a little bit later on, and this is
Yes.
just our first crack at some of this, but
Yes.
there's a lot embedded in everything that you're saying, and it's so it's we have a saying in our committee, it's more complicated than that. So
I think that the hardest test in explaining a health policy is to stay at a high level. It's certainly a hard test for me. In our agreement, we're setting out to control healthcare cost growth by setting clear targets for what the healthcare cost growth should be. We are in this agreement now. We're in performance year 4 of the all payer model agreement. It's performance year 4 of 5. So we have 2 full performance years left in the agreement. When we conclude all 5 performance years, our growth in this agreement should be 3.5%, actually to 4.3%. So we have room up to 4.3%. 3.5% growth in healthcare costs over that period is the aspirational target. And in order for Medicare to be interested in participating in this model with us, Medicare specifically wants to see its growth be slowed in the state of Vermont. And that means that Medicare would grow more slowly in the state of Vermont than the national projections for growth in a particular year. And then here, finally, I note that the agreement requires alignment across payers, and the agreement has significant targets for participation, which are called scale targets. The scale targets provide for the state having 70% of its residents attributed to the model by the end of the performance period and 90% of Medicare beneficiaries attributed to the model by the end of the performance period. And we do have work in that arena that is important.
Ina, real quick then, going back to that slide briefly, when you talk about all payer growth target, then what we're saying is because we're paying for the whole patient and care is given based on a flat amount of a budget, sort of the global budget for providers in this case, we're not saying that we're reducing the amount that's being paid. But what we are saying is that the utilization is, the request for those funds is less. We are saying that under a fee for service system, the cost would be higher. I'm trying to relate this to, trying to ask the question, what are we saying when we say growth rate at 3.5%? We're not putting a cap on expenditures.
What we are saying is that we are in this agreement held to an amount of healthcare growth not to exceed 4.3% on it, not to exceed 4.3%, and that is evaluated on an annual basis, and we are evaluated to see if we're on target to meet that aggregate compounded annualized growth rate. It is a cost growth moderation target. It means that healthcare spending is still growing year over year, but that it is growing in accordance with this target and perhaps not growing unfettered without any kind of control or target for spending.
So if we were to compare this growth rate, our target rate, with annualized growth rates outside of the state of Vermont or outside of the program, the difference would be what?
I would ask that you look to the Green Mountain Care Board
Okay.
for comparisons of national healthcare spending
Okay.
at this time. And in fact, I'll take the opportunity to move to this next slide to explain a little bit of who does what in this healthcare reform initiative, because there are many partners, essential partners in the initiative, and there are 3 signatories on the agreement with the federal government, in fact, and each with particular requirements per the agreement. And the reason I'm moving to this slide now is because the Green Mountain Care Board has the chief responsibility for monitoring and reporting to CMMI on the state's performance under the agreement. And so they are expert in how we're performing. So our agreement is between the state of Vermont and the Center for Medicare and Medicaid Innovation, and which is the innovation arm of the Center for Medicare and Medicaid Services. The Center for Medicare and Medicaid Innovation was created by the Affordable Care Act in 2010, and it is an engine specifically for the purpose of testing different payment models for the Medicare program, payment models that otherwise couldn't have necessarily been tested without significant oversight by Congress. So that is a key component of the Affordable Care Act. The Innovation Center also is funded to develop and to work on innovative approaches to healthcare delivery and payment, and to do so with states, and certainly with the goal of being able to potentially standardize and promote new models across the United States. So there we have an agreement with CMMI that allows Medicare to participate in this initiative, as I said. And that agreement is where the targets lie within that agreement. And CMS came to this agreement certainly from the point of view that if other payers joined with Medicare in paying differently, that the opportunity for Medicare was greater. CMS is very much interested also in savings for its own programs, and interested in Medicare over time growing more slowly. Healthcare cost growth trajectory are not just not sustainable from a state perspective, but not from a federal perspective either. So that's why this innovation center is such an important partner. And it's also helpful to recognize that it's driving a posture for Medicare. It's driving it for Medicaid as well. And I think it's important to note that posture of moving away from fee-for-service has been consistent at the federal level, now looking back across 2 administrations, beginning in the Obama administration and then staying consistent throughout the Trump administration. The federal partners that we have are continuing to emphasize a movement away from fee-for-service reimbursement. So they too really want to pay providers differently than a pure fee-for-service model, and recognize that there is opportunity there in curbing healthcare spending and healthcare cost growth. And that's been reinforced in multiple ways. And there's also bipartisan legislation that was passed in 2015 that ties Medicare rate increases to quality and performance in alternative payment models, or to quality and performance reporting in a system called the merit-based incentive payment system. So back to implementing payment and delivery system reform in the state of Vermont. The Green Mountain Care Board is providing health system regulation in this agreement, and it is supporting the model goals it's providing ACO oversight consistent with Act 113 of 2016. It also, through the agreement specifically, is responsible for assigning the Medicare ACO program design. So in this model, which is very expansive, Medicare doesn't only pay differently an ACO in the state of Vermont. The Medicare program and what that looks like can be customized for the state of Vermont, and it is the Green Mountain Care Board that has that responsibility to provide for the customization. Our federal partners do approve what that looks like, but that responsibility lies with Green Mountain Care Board. They're also responsible, like I said, for monitoring and reporting to CMMI on the cost growth targets. So how we're growing, they're looking at how we're growing relative to national, where we are in terms of scale, how many payers are participating, how many providers are participating, and therefore how many Vermonters are attributed to this model. And the board is responsible for looking at the quality targets in this agreement and the specific quality metrics that the agreement holds the state responsible for, which include 20 different metrics. The governor and the Agency of Human Services are also signatories on the all-payer model agreement. You're going to get a detailed deep dive, I believe, about the Vermont Medicaid Next Generation ACO program. The agreement requires that our Medicaid program offer an ACO program that meets with the requirements for moving away from fee-for-service, and we do that through the Vermont Medicaid Next Generation ACO program. This program began in 2017, which was actually performance year 0 of the agreement. This program is easily the most advanced in how far away from fee-for-service it has moved. It includes a fixed prospective payment to providers who are able, through the Accountable Care Organization, to receive that fixed prospective payment. And that means, and you'll hear about this in more detail from the Next Generation team, that means that, for instance, during the pandemic, when we needed to curtail elective procedures and non-urgent healthcare services in order to ensure that there was capacity for a potential surge, as well as to ensure safety in understanding with respect to transmission risk. That means that for healthcare providers who were being paid fee-for-service, all of a sudden they weren't delivering services, so they weren't getting paid. With the Vermont Medicaid Next Generation program, in this instance, provides a very clear case for prospective predictable payments, because those providers that were enrolled in this program received their anticipated dollars for the Medicaid population at the beginning of each month. So that means they were guaranteed that revenue, they had that revenue, and it was something that they could rely on when other revenue fell away. So it's it demonstrates a clear case for the predictability and the stability that a fixed prospective payment can offer to the healthcare system. And it is certainly something we would like to see, that true fixed prospective payment be expanded. And that is a part of our implementation improvement plan, to move more of the payments into the predictable fixed model. So that's the chief.
So are you finished with this slide, or do you have one more?
I can move really quick. That I was going to just summarize by saying the chief role of the Agency of Human Services probably is with the Medicaid program that we offer. We also need to have an ACO or ACOs in the state that can accept alternative payment. Their key partners and private insurers have to be willing to contract with ACOs. So they are key partners in this model as well.
Okay, and there are a lot of questions that are embedded in this slide in particular. So when you talk about rate setting at the Green Mountain Care Board, reality is that for private insurers, rates setting, actuarial analysis, and solvency takes place in DFR, Department of Financial Regulation. So it's more of an approval process for rates, but for hospitals and so on, it becomes more of a more in-depth process. So that's and then the other, I guess that I'm trying to point out some of the concerns that we've identified. There's Wally. He is a good helper. One of the current concerns that we've had is the differential rules that exist, and for trying to align all of the payers that we have before us and all of the systems that are before us. But there still are different rules embedded in private insurance and embedded in Medicare and Medicaid, regardless of the work that we've done to bring things together.
Absolutely.
Okay. Ruth, did you have a question?
Yeah, thanks.
Senator Hardy, sorry.
I can wait until you have 2 more slides. I can wait until you're done, Ina, if that's easier for you, or I can ask my question now.
I'm happy to take a break.
Okay. I love to see your child climbing on your shoulder like that. It's very adorable. My question is, I mean, one of the major health outcome goals is about reducing suicide and reducing overdose deaths and sort of not what we would consider things that are necessarily directly related to going to the doctor and getting your annual exam or whatever. So are the mental health providers all part of this system? Are the community, the what are they, the DAs and the whatever they're called, SSA? I don't know all the letters yet. But and how has it changed the delivery and payment system for them? And also home health providers, and you mentioned long-term care. I'm assuming they're all part of it. And how are they paid differently? Because there's just seems to be a chronic problem with payment for mental health services in our state.
Really excellent question. And one of the I think key kind of differences with Vermont does just have one accountable care organization. And there are many accountable care organizations around the United States. Many of them are hospital and physician based, meaning their providers that are in their network are primary care chiefly, or hospital and primary care. One Care Vermont does have a very diverse network of providers. The designated agencies are a part of that network. And I'll certainly defer to One Care to really describe to you who participates with them. Home health agencies also participate in One Care's network. And there's also opportunity through the care model and the care coordination design for those providers and designated agencies, for example, to be the chiefly responsible for care coordination, or and then for that to be compensated for that care coordination activity. That is one example of how the ACO with this broader network is incentivizing the care delivery in a more, I would say, incentivizing a more holistic approach to care delivery.
So what I'm going to do is the question that Senator Hardy asked is really an important one. And I think if we can go through and finish your slides, and then after we've heard from the ACO,
Yeah.
I do encourage, I would say that the goal that we've been reaching toward is a completely coordinated, integrated system of care from acute to chronic. And so if you move from an acute care setting or a physician's setting where there's a team available to support mental health counseling and so on, that it would be a seamless transition to the services that are out in the community or at home. So that's, for me, that it continues to be a strong aspiration. And I think what we'll do is we'll come back to this, Senator Hardy. It's a great question, and I think it's a really important one in terms of mitigating acute events in people's lives. So,
Okay, thanks.
yeah, it's good. Thanks. So, go ahead.
Okay.
I think we only have about 5 minutes left. So we'll just let you go. It's 10 o'clock, 10:12 right now. So we'll let you go ahead.
Okay, so just a few highlights. I've tried to give an overview of the all-payer ACO model agreement, and now I want to highlight a few very important things about the agreement, and then close with talking about where we do understand that we have room for improvement in this model, and where we need to make improvement in order to understand the efficacy of this model. But first, I want to highlight some key things. This model agreement, as we talked about, it's not a coverage model. It's a model of paying providers differently and improving the way that care is delivered. So all of the beneficiary protections that are consistent with an individual's coverage stay completely intact with the implementation of this model. There's no part of your coverage plan that comes into question with this model. All of the coverage that you have today is entirely the same. I think that's important to remind people about when we're talking about a large scale healthcare reform. And it's also, I want to highlight that Medicare through this model does provide some benefit enhancements that otherwise are not available to Medicare beneficiaries. Through this model, Medicare offers post-discharge home visits, and that means when a person leaves the hospital and goes home, regardless of whether or not they're medically homebound, they can receive a visit at home to understand and determine safety of the home environment, perhaps to do looking at medication, and to make that transition from hospital to home more seamless. Whereas Medicare, without this model, Medicare doesn't pay for that. There's no payment for a visit in your home when you've been discharged for the hospital if you don't qualify as homebound. Also, through the model, there's the ability to access skilled nursing care more easily without having to meet the complicated Medicare rules that otherwise exist. A person, if skilled nursing care is the right level of care for an individual, that individual through this model can go directly to skilled nursing care. And finally, telemedicine services, which I think we can all appreciate, have a much we have a much larger understanding now of the importance of telemedicine services and how essential they are for maintaining continuity of healthcare services when we're in a situation where it's important to be remote. And while it might seem surprising, Medicare was not covering telemedicine services in those Vermont counties that were considered to be metropolitan. So Chittenden County, for instance, Medicare wasn't going to cover or does not cover telemedicine services. Because of this model, it does. So if you can receive those services through the accountable care organization. And the model encourages providers to better coordinate patient care and services, as we've discussed. It may lead to more meaningful time spent with your doctor because there is this emphasis on the coordination of services and the preventive nature of the services. And the model does link healthcare outcomes for the population in a meaningful way with the healthcare delivery system. It doesn't mean that the healthcare delivery system alone is entirely responsible for reducing deaths due to suicide and drug overdose, for example. There's very much a partnership between the healthcare delivery system and social services and supports that are otherwise available. This model also provides federal monies that continue funding for our Blueprint for Health and SASH programs, support and services at home. These services were funded by Medicare prior to the model. Medicare was going to cease funding for these services, but agreed that they were key, fundamental, and foundational services for healthcare reform in our state, and that the monies could be provided through the Accountable Care Organization to maintain federal Medicare participation in these programs. And finally, this model, as I've said a number of times, the federal government is really pushing to move away from fee-for-service reimbursement, and we're able to do so in this model on our state terms. And that I think that that's really critical. And the testament to that is the way that we're able to maintain that federal participation for our Blueprint for Health and SASH programs. And finally, like I said, we're very much in the process of implementing this model. This isn't in concept. It is very much underway and happening, and has been now for 3 full performance years. And the fourth is we're early in the 4th performance year. Over those 3 full performance years, we can observe where we need to make improvements in order to realize and to really examine how this model functions and if it can meet the hypothesis of paying providers differently and doing so at scale. And in order to improve our performance, we've identified 4 key areas. And again, these are a part of the implementation improvement plan that the Agency of Human Services published in November. We can certainly take time to talk about what we recommended in that plan and how we are working towards those recommendations, but they fall into these 4 key areas. There is work we can do with our federal partners to maximize the agreement framework and make it work as well as possible for the state, and to acknowledge where there are places where where the agreement may not be entirely realistic. We also know that we can reorganize and prioritize healthcare reform activities within our own Agency of Human Services. And in fact, we have done so by moving the reporting structure for the Blueprint for Health program, as well as the Health Information Exchange programs, to the Healthcare Reform Office in the Secretary's office. And so we now are joining those activities. And that is really looking all the way back to 2013, building on the foundation of the Blueprint for Health and our health reform activities. It makes really good sense for those to live together in the same place. We also know that the regulatory framework that the Green Mountain Care Board employs in its regulatory work can be further evolved for a value-based payment model. There's many years of regulatory history, as I pointed to with some of the highlights of healthcare reform activities in the states. We've been looking at hospital budgets through regulatory mechanism in Vermont for quite a long time, but that has been a long time of looking at a fee-for-service payment model for hospitals. So the regulatory framework needs to evolve to acknowledge and to be responsive to a value-based payment model rather than fee-for-service. And that means some different regulatory approaches, which I think the Green Mountain Care Board would be happy to talk with you about. And finally, strengthening the ACO leadership strategy is another area that we identified as key in improving our performance in this agreement, because we know that there are more opportunities for participation with the ACO. And we know that those opportunities for participation certainly could be considered alongside the core business of the ACO, and how the ACO is offering something to providers and payers that is attractive and that is very, very clearly supportive of moving away from the fee-for-service reimbursement model.
Ina, I thank you. This has been extremely comprehensive and a terrific introduction to where we are today. We all greatly appreciate it. And we will have you back in and others to talk about the implementation plan, next gen implementation plan. Probably not for a couple of weeks, but thank you. And I don't like doing this, but we do have other witnesses waiting. And so I think that we haven't seen the last of you in this committee. We're surely going to have you back. And thanks for being here. Committee, I think if you have questions for Ina, write them down, and then we'll make sure that we get those answered going forward. Okay, just nod your head yes or no, or it's okay.
Thank you, Ina. This was
Yeah,
great.
thanks a lot, and give Wally a hug. Okay, all right, so that's a lot of information in a short period of time. And I think there's a lot to digest there, so do take some time and go through that slideshow, and do write down some questions. I have some observations as well, and some things that we tried to do before the pandemic that maybe we'll come back to ultimately. But we are honored to have Senator Sears here to present his bill on S42. Has a new name this year. So Senator Sears, thank you for being here. And why don't you give us a quick introduction to S42? Because we do want to work on this as quickly as possible.
Well, thank you, Madam Chair. Appreciate it, and appreciate being here. All the members of the committee, with the exception of Senator Terenzini, will probably recognize this bill. I can't remember the number last year, but other than the dates,
it was 243. Just
240. S240. Other than the dates, nothing has changed. But the goal of the bill, actually, now Commissioner Baker came to me of Corrections, who's a constituent of mine. He and I had coffee pre-COVID, before he was Commissioner of Corrections, and had a long conversation about the number of folks who are in law enforcement, corrections, and other jobs who are suffering from extreme problems from those related jobs, and particularly the stress of those jobs and what they see on a daily basis. And I can't remember the numbers he talked about in law enforcement who've committed suicide, but he was tremendously concerned. He had an award that he had received from some group, and I can't remember the group, but he had decided to pay it forward and use his own money, or the money that had been rewarded, to have a host a big event at the Capitol Plaza. Again, I think it was a year ago, December, and he was amazed at the number of first responders who came. It was in the 250s. There are a lot of people who need this type of wellness commission, and that's what this bill does. It sets up a wellness commission to try to recognize what many of these first responders go through on a daily basis, and Obviously, during COVID, it's even been more stressful for many of them. In my own local police department, it's about 22 sworn officers in the Bennington Police Department. 6 of them were out with COVID. That meant stepping up tremendously by other officers. And having something like this for them to be able to go to or help them to deal with some of those stresses would be interesting. And we've seen throughout the state cases of domestic violence and other factors amongst law enforcement particularly, but others who are on the front lines dealing with things on a daily basis. A good friend of mine is he used to work for me, and then he decided to become a ambulance driver and helping people out in emergency situations. And he talking to me about the number of overdoses he sees and the number of times he has to give Narcan to people and how stressful that is for him, just seeing it over and over again, and many times the same people, and getting frustrated with that. So I think it's just a thing whose time has come to recognize that and see if we can't do something special here in Vermont. I would really urge you to hear from Commissioner Baker. It's really his baby.
It is, and we will. I think we have him on our list on, is today Wednesday? I think it's tomorrow. Yeah. Yes, so we will get him in. He's been a strong leader in this area, and we definitely need to hear from him. So, committee questions for Senator Sears on the bill, the motivation for the bill. Senator Hardy.
I'm just scrolling through Senator Sears. So thank you for coming and presenting the bill. I agree that it's a really important issue that we need to address. I'm wondering if the language as it currently is, if it includes any kind of public outreach and education to make the public more aware of this issue. I think a lot of people have no idea how stress impacts our first responders. I, for example, have a very good friend who a year and a half ago, he's a firefighter, had a heart attack, and he's not that old. He's my age. And
he's a baby.
well, I'm not quite a baby, but he's not in the sort of high risk category, except for the fact that he's a firefighter, and firefighters have a much increased prevalence of heart disease and heart attacks. But I don't think most people know. So I'm wondering if this includes any kind of public education about the issue, or so that people realize that their behavior can impact the stress on our first responders.
Yeah, I think if you look at page 3, line 8, to educate the public, emergency service providers, state and local governments, employee assistance programs, and policymakers about best practices, tools, personnel resources, and strategies for the prevention and intervention in the effects of trauma experienced by emergency service providers and law enforcement officers. I think that, obviously that could be strengthened to accomplish what you're talking about. I think it's a great point. And I certainly would say that was kind of the intent, but it may not be as direct as what you just said. And I think that would be a great addition to the bill.
Great.
Good.
Okay. Thank you so much.
And as we go through the bill with Katie, we'll pick up some of those. Senator Terenzini.
Thank you, Senator Lyons, and nice to see you, Senator Sears.
Good to see you, Senator.
Reading the bill, my initial impressions are that it serves a worthy cause. I have a lot of friends and family in emergency services and first responders. I spent 9 years on my local volunteer fire department, and mental health is such a critical piece to the success of any agency and for the safety and betterment of a community. So I appreciate most of the language in this bill, and I look forward to seeing this play out. So thanks for being here.
Thank you. Thank you for the support. Appreciate it.
Questions, other questions, committee?
This is so much easier than S30, the firearms bill.
Well, you're welcome to stay. I mean,
I think some would consider that hiding, so I better go back.
uh, listen, we really appreciate your being here and bringing the bill back to us. It is one that we want to get to work on. So,
But I have to give all the credit to Jim Baker. This
Yeah.
was his
Well,
idea. We're
and we
merely the
will.
conduits, Senator Campion and I, although Campion will try to
He couldn't have
Yeah.
picked a better set of conduits.
Right. Thank you so much,
All right,
committee.
take
Appreciate
care.
the time. Bye now.
Thank you.
Now I got to figure out how to get back into judiciary. Can't just walk around the corner in the
Oh,
hallway.
don't worry. You can come back anytime.
Thank you so much, Chair. Bye now.
Okay. So I know that at Tom Boris, you are here, and we're going to spend just a few minutes going through this bill. We're a little bit behind, but we will catch up. And Tom, are you there?
I am here, and that's
You
no
are
problem.
there. Are you under any kind of time crunch?
I am not, so please take your time.
All right. Well, so we'll do this, and then because we have our ledge counsel here, and then we'll come back and have you present to us about the ACO. So thank you, and thanks for your patience. All right, Katie,
Morning.
welcome.
Thank you. I'm prepared to walk through the bill, and I'm wondering how much time you have. Do you want me to do something kind of very high level, or do you want to look at the words?
Well, let's do sort of high level, and because
Okay.
we do have this scheduled again, we have some time. I think is it tomorrow? Somebody help me. So we'll be back to look at it again when we have witnesses, and I'm thinking you'd be available then, and we'll get into the weeds.
Okay.
we do
So
that.
what I'll do is I'll pull up the document right now, and I'll
Okay.
just kind of scroll through quickly so you can see the different elements. And let's see that I pull up the right document.
And just a reminder to the committee that this bill was reviewed, evaluated, improved by both the Health and Welfare Committee, and then GovOps did a drive-by with it, as they are again this year. So just so you know, it has changed from the original bill last year. All right, go ahead, Katie. Sorry to.
Sure, no problem. So S42, Senator Sears did a great job of teeing it up. This bill creates an Emergency Service Wellness Commission. It's a commission that's made up of, I want to say, about 25 or 26 different members who are all either providers or mental health care professionals. And the focus of the bill is on identifying resources, generating capacity, identifying both the public and members of the emergency service provider community about how to support this particular group of people who serve the community. So we start off with the definition section. The definition that I would bring your attention to is emergency service provider, just because we're identifying a number of different types of providers. So a current or formerly recognized by a Vermont fire department as a firefighter, somebody who's currently or formerly licensed by the Department of Health as an emergency medical technician, emergency medical responder, advanced emergency medical technician or paramedic, someone who is currently or formerly certified as a law enforcement officer by the Vermont Criminal Justice Training Council. And it was pointed out to me that since this bill, since last year, this council name has changed. So if the committee is to move forward with this bill, we have to change that in two places. Next, somebody who is currently or formerly employed by the Department of Corrections as a probation, parole, or correctional facility officer. And lastly, somebody who is currently or formerly certified by the Vermont Enhanced 911 Board as a 911 call taker or employed as an emergency communications dispatcher, providing service for emergency service provider organizations. So then we get into the duties of the commission. And this is really the heart of the bill. So this is why we're creating a commission. And there are 9, I believe, 9 different duties. So I'll try to go through them fairly quickly here. The first is to identify or increased or alternative supports or strategic investments with the emergency service provider, DAs, SSAs, or other community service systems could improve the physical and mental health outcomes and wellness of emergency service providers. Second, identifying how Vermont can increase capacity of clinicians to treat emergency service providers. Third, creating materials to inform in consultation with the health department, including a list of qualified clinicians for the purpose of populating an electronic emergency service wellness resource center on the Department of Health's website. So this is asking the Department of the Department of Health to create a website and to post various resources for the emergency service provider community on that website. To the point that Senator Sears made, subdivision 4 is educating the public, emergency service providers, state and local governments, emergency assistance programs, policymakers about best practices, tools, personnel, resources, and strategies for prevention and intervention of the effects of trauma experienced by these providers. Subdivision 5 is identifying gaps and strengths on the system of care for providers. 6, recommending how peer supports and qualified clinician services can be delivered regionally or statewide. 7, recommending how to support providers in communities that are resource challenged, remote, small, or rural. Subdivision 8, recommending policies, practices, training, legislation, rules, and services that will increase successful interventions and support for emergency service providers to improve health outcomes, job performance, and personal well-being, reduce health risks, violations of employment, and violence associated with the impact of untreated trauma. And lastly, the duty to consult with federal, state, and municipal agencies and organization entities and individuals in order to make any other recommendations the commission deems appropriate. So those are the 9 duties outlined for the commission. And then we go into the list of members. And I said it was, as I said earlier, it's quite an extensive list. So I don't know that I'll go through it in detail at this point, but we have members of the administration. We have representatives of different branches of emergency service providers. There's also members representing community mental services. And I guess we'll go through this, the League of Cities and Towns, peer supports. So we will.
You know, and Katie, I think we've almost gotten to Z with this one. We got to W.
Right.
I suspect we're going to have a request to get an X during some of our testimony. So we'll see what happens.
So just trying to move right along, this says that the members will serve for 3 years, and there's some language about how a vacancy is filled. In subdivision 3, it indicates that members are to recuse themselves if there's any discussion of an event of an emergency service provider that's known to that member, and there can be an interim replacement member appointed to the council just while that particular incident or circumstance is being discussed. In subdivision, this kind of language about how the commission is to be administered. So we have the Commissioner of Health calling the first meeting by September of this year. The commission is to select a chair and vice chair from among its members. And the commission is to meet as necessary, but at least once each calendar quarter. And the health department is to provide assistance to the commission. Subsection E has to do with confidentiality. So the meetings are open to the public, but the commission could go into executive session if there's an event involving a specific emergency service provider that's being described or discussed, even if that person isn't specifically identified by name. And then similarly in subsection F, the records that describe an event involving a specific provider are exempt from public inspection, even if they don't identify that particular person by name. In subsection G, this is language that the commission could enter into agreements to attain otherwise confidential information. And then subsection H is a reporting requirement. This language mirrors language of the Mental Health Crisis Commission that was passed a couple years ago. So basically the commission is to report conclusions and recommendations to the governor of the General Assembly as necessary, but at least once each calendar year. The report can shall disclose individually identify health information only to the extent necessary to convey the commission's conclusions, but any disclosures are limited to what's already known by the public. And you'll also notice this language on line 15, notwithstanding 2 VSA 20D. Our reports generally have to go through a review every 5 years by statute to determine if the committee still wants to receive the the report, or if the committee no longer needs that report. So by notwithstanding that provision, this is saying that this report would come in every year and not be subject to that 5-year review of whether it's still necessary. And that's it. The effective date is July 1, 2021.
Good, thank you. That was actually pretty thorough. Appreciate it. And some of the sections of the bill relating to how the meetings proceed, confidentiality, are the sections that GovOps will look at again. So that's helpful. Questions for Katie? Okay, we're good. And we'll be back with this bill. I'm trying to remember my agenda. I don't have it yet.
Tomorrow, I think.
It's tomorrow at 11.
Thank you, Nellie. Okay, so it is tomorrow at 11. Jen, are you going to be here?
Katie, I don't think it's on my calendar. I don't know that.
Gosh, at least
I might be booked in one of the committees upstairs. Let me check. It could be something that I could.
That's okay. You sort it out, and
Okay.
If we have burning questions, we'll save them for you. But thank you. We'll be good.
No problem.
Sorry about the miss. If I'm not looking at the screen, I just first name.
Not a problem. I also go by Hey You.
I know. Okay. Okay, we're good then. Folks, just so you know, we do have testimony on the bill tomorrow, and I haven't heard anyone say this isn't a good idea. So I think Senator Cummings, you think it's a bad idea?
No, I reported it.
Oh, okay. Well, that's
I remember
awesome.
saying on the floor, it's a basic boilerplate, boring bill. The compelling thing was the testimony, and I'm hoping we'll get the providers in for that testimony, because that was powerful.
Yes, it was. And I believe that some of the folks that we have tomorrow will be able to convey some of that intensity. Very compelling testimony. Okay, so we'll move ahead with this one. And now we'll move ahead with our agenda. And Tom Borys is here. He's the CFO of OneCare Vermont, our one ACO at this point. And Tom, thank you for being here again. And I will turn it over to you and allow for you to go ahead with your presentation. And then following that, we're going to take a little break. So you go right ahead.
Well, thank you so much for having me. It's been quite a while since I've spoken with this committee. Last time was in person, so that means it has been a long time. But really nice to be here. My name is Tom Borys. I'm the Vice President of Finance for OneCare Vermont. And I was asked to come and give kind of a high-level overview of what an ACO is, what OneCare is, our role within the all-payer model. I did listen into Ina's presentation earlier, so I think some of the material will feel similar in nature. So Chair Lyons, please shoot me along if I'm covering material that you guys feel like you have well understood at this point.
It
I'm gonna-
doesn't hurt to have repetition about this information. So if it gets too long, we'll let you know, but please go right ahead.
Great, thank you. And then happy to entertain lots of questions as well. So whatever's on your mind as it relates to One Care Vermont and ACOs, happy to get into a dialogue. So this one, first slide here, what is an accountable care organization? As Ina mentioned earlier.
Tom, your screen is not yet shared.
Oops, I'm sorry. How about now?
Ah, perfect. We
Okay.
have it now.
Great. All right. So an accountable care organization, as was mentioned earlier, is a group of providers. And these providers come together voluntarily to deliver high quality and coordinated care. That word coordination is important. I'll touch upon it in a few moments. Really, a key tenet of this model and idea is that when an ACO succeeds in both delivering the high quality care and effectively using healthcare dollars, it shares in savings it achieves. And I'll talk about how that works functionally in a few minutes as well, but that concept is quite important. And then how does One Care Vermont fit into what an ACO is? So One Care Vermont is an ACO as an entity, and really functionally, it's the hub or the link that brings the providers together. We contract with all the different providers who wish to be involved in ACO activities. And then as a whole, we then contract with payers such as Medicare or Medicaid to enter into these ACO agreements. So think of us as the linkage that brings everybody together into one place. I did take some of the language here from the CMS Medicare website, so I just referenced it down below. It's a good resource as well if you want to go a little bit deeper into what an ACO is, the origin behind it. It's a good resource. So next, I'll talk a little bit about the One Care Vermont structure, how we are organized and how we function as this hub. As I mentioned, One Care is led by its board of managers, and that board is comprised of participant representatives. And we strive to have a diverse board and representatives from all different provider types that participate in our programs. So that includes independent primary care, home health, federally qualified health centers, hospitals, et cetera. This board is responsible for key decision-making and direction of the ACO, and like many other organizations, relies upon subcommittees such as the Finance Committee or the Population Health Strategy Committee to go a little bit deeper on topics, gain input from a broader array. So we have a board, but we can include more participants on these subcommittees and make sure that their voice is heard when decisions and key decisions are being made by the board. At its origin, One Care was founded and remains co-owned by the University of Vermont Medical Center and Dartmouth Hitchcock Health as a nice partnership between those two entities, and really to help get this ACO model off the ground in Vermont. All right, so the first word in the ACO acronym is accountable. So how do the providers really take accountability? The way that this works is that when One Care enters into a contractual relationship with a payer, part of the process is to agree upon an appropriate amount of healthcare costs for the patients. So starting with the patients are generally assigned to a primary care provider. So there's the payers do this, but they have a mechanism called attribution where they look at claims and say, for the participating providers, here are your patients. Next, the actuaries employ their craft and they come up with an appropriate healthcare cost number. So for example, if you had 20,000 attributed lives, the actuaries may say, reasonably, it should cost $120 million to take care of the healthcare needs for these patients. At the end of the year, there's basically an accounting that says, what did it actually cost? Did it cost 121 million, meaning that too much was spent, or did it cost less? And that difference ends up being what's referred to as shared savings or shared losses. If the actual healthcare costs end up being too high, the ACO owes money back to the payer. If the actual healthcare costs come in too low, or low, which is what we want, then that materializes as shared savings. That's how the ACO and the providers share in the savings with the payer. Functionally, there's a lot of complexity to how that's done, but that's how the accountability is transferred to the providers. And ultimately what it means at the end of the day, and this is really important, is that the providers are rewarded if they do a really good job managing the health of their patients. Pause there for just a half second because I think that's just important material. All right. Next slide. Population health is a term you'll often hear when speaking to OneCare or other ACOs. And really, what does it mean? Based on the previous slide, when I said about how the target is set based on a population, the 20,000 lives I used in that example, when the providers are accountable for the full array of the healthcare costs, so that includes care at their local primary care provider's office, it could be at a home health agency, it could be at a local hospital, it could also be at a hospital out of state, Mass General, or somebody's down in Florida, for example. The focus shifts to the holistic healthcare needs of the population. This is an important paradigm shift. And really what we hope happens through these ACO models is that it promotes enhanced coordination and collaboration between providers. I think it will come as no surprise that many patients see multiple different providers. They may see, as I mentioned before, a primary care provider. They might have a home health worker. They may be engaged in the designated agency system. And to really effectively manage the health of the population and hopefully succeed in the financial model, that coordination and collaboration is essential in making sure that the patient's care is well organized, they're receiving the right care in the right way. In addition to the financial paradigm I mentioned before, there are quality measures that come with these programs, and they are designed to really evaluate whether or not the ACO is adhering to population health best practices. And one example is if a person is admitted to the emergency department for a substance use disorder event, it's best practice to have a follow-up after that event occurs to make sure that they are receiving the appropriate follow-up care and they're not, so to speak, lost in the system. They had this one event and then they're just on their own again. So the quality measures are designed to make sure that we're monitoring, paying attention to, and adhering to some of these population health best practices. So OneCare's core business areas, we are a network of providers and everybody has a little bit of a different role to play. So in addition to all the bring the providers together and then contract with the payers like Medicare or Medicaid, there are certain business functions that OneCare facilitates on behalf of its network and in support of its network of providers. The first is a statewide care model. This is, and actually I'll speak about more detail, but the next, data and analytics. This is a huge value add that the ACO brings, in my opinion. And the last that Ina spoke of quite a bit was payment reform. So first on the statewide care model, OneCare's programs and ACO programs in general largely revolve around primary care. That's the way in which patients are assigned to the ACO, and you can think of the primary care provider in some ways as the quarterback for the patient's care. Thus, we invest in primary care, really believing that they are the providers and the entities that have the best ability to impact the overall cost for the attributed patients. One thing that's unique about OneCare is that our network includes all the different provider types I've mentioned before: mental health, social services, home health, skilled nursing, et cetera. I've spoken to leaders from other ACOs that are solely primary care. They're only primary care providers in their ACO model. And I asked them, so what's your relationship with the hospital or some other providers? And they have none. So they're literally on their own. And what we have tried to do at OneCare is develop a much more inclusive and diverse network so that this system can work better together. And we can share information, data, best practices in spirit of a healthier population that hopefully achieve the goals set forth in the Vermont all-payer model. Another aspect that I think is really important is as we shift to this value-based healthcare model where providers are rewarded if the population is healthy and well managed, there is a new incentive on prevention. In the fee-for-service based system, there really isn't a strong incentive to prevent illness. I say that noting that every provider I've spoken to is well-intended and wants the best for their patients, but there's no financial incentive to invest in activities that can prevent an admission or help avoid somebody with diabetes going out of control. So it's a really important factor is that when we switch to this population health accountability model, there is on these preventative activities. And I think that is a really important concept. Next is data and analytics. So when we, as an ACO, enter into an arrangement with a payer, part of the agreement is that we receive data and data feeds that help us understand the population for whom we're accountable. So we will receive a monthly data feed, for example, from Medicare that has within it claims data that shows for all these attributed patients what care they're receiving and from whom. This is really important. It allows us to do a couple of different things and analyze data through different perspectives. The first is on an individual patient level. We can evaluate the healthcare services that an individual patient has been receiving and identify those who have more complex healthcare needs and make sure that providers are aware and maybe recommend or encourage a care coordination plan, for example, around these patients. We can also look at provider behavior, and we can take the data in aggregate and compare primary care provider A and primary care provider B and identify areas of opportunity. And while, again, I do believe everybody's well-intended, when you look at data, there is variation where one provider may be more prone to referring to high-cost imaging than another provider. And not to say that that's necessarily wrong, but it's worth exploring. Maybe there's some best practices that can be shared or some areas of opportunity. One example here that came out of Brattleboro in the bottom is that they noticed through these data that their colorectal cancer screening rates were low relative to other communities within the state, and they responded to it and built in a protocol to evaluate and enhance those rates. And absent these data feeds that come into the ACO, that's hard to see. The payers may have some of that data, but that communication between the payer and the provider is not easy. Having the ACO as the intermediary to share that data, do some of the analysis is really important. The other component that I think is important here as well is providers often have a really good idea of what they're doing in their office, but they don't necessarily understand what a peer provider is doing. And my background's in the mental health system. I worked in the designated agencies for nearly 12 years. And my experience, we knew what we were doing for the patients in our shop and had lots of data there, but we had no idea what the primary care provider was doing or whether or not that patient was in the emergency department the night before. It's possible to get that information, but it's cumbersome through approvals to share data, things like that. So by having the ACO arrangement in place, we get that holistic data feed for the patients and can make sure that the designated agency caseworker understands whether or not the patient was in the ED the night before and can provide the appropriate follow-up. All right, next key area is payment reform. So I agree with what was said earlier in terms of moving away from volume-based reimbursement. And the term that we often use is fee for service. So you provide a service and you get a payment for that particular service. We can talk for days, I'm sure, about the pros and cons of that. I think there are more cons than pros, in my opinion. But one of the strategies that we think is really important to help us succeed is to move the paradigm away from the volume-based reimbursement. And one of the key ways that we've done that in the early onset of these programs is to facilitate conversion to monthly lump sum payments. So generally speaking, when we enter into negotiations with a payer, this is an option that we can put on the table for discussion. And the idea is that you have the actuaries evaluate what the historical spending baseline would have been, and that is based on fee for service, and that enables a smoother transition from point A to point B. But we agree upon an amount, and what happens is the payer will turn off the fee for service reimbursement for participating providers, and then instead they pay a monthly lump sum payment to OneCare Vermont. OneCare Vermont then takes that monthly lump sum and we divide it up using our models to the participating providers. Now, I mentioned before that in that example of 20,000 lives and $120 million of healthcare costs, that $120 million can happen anywhere. So really what we're converting is a portion of this spend to a fixed payment, and where we focused early on is in hospital reimbursement. The reasons for that are, comparatively, there are fewer. There are 14 in the state, so there are fewer to address, and they have a significant amount of the healthcare costs. So we can take a large bite by focusing on the hospital conversion out of the gate. The other reason to focus on hospital conversion from fee-for-service to these lump sum payments is if we're wildly successful in these population health initiatives, it's the hospital revenues that would go down the quickest. You'd see, and this would be a good outcome, you'd see a reduction in ED utilization or a reduction in inpatient admissions. That is what we want to see, but we want to make sure this is a smooth, thoughtful transition. We would not want to pull the financial rug out from any of our participant hospitals, as I think it honestly would be deterrent to participation if that happened too aggressively. In addition to the hospitals, though, while that has been the main thrust thus far, we do offer a monthly lump sum payment model to independent primary care. And this is a program that we call the Comprehensive Payment Reform Program. It started off as a pilot, and it's been in place now for a couple of years. So I think it's probably time to take off the pilot label. But it was intended to be a pilot to test whether or not we could come up with a payment model, call it an algorithm, that determined an appropriate payment to an independent primary care practice that was disaggregated from historical fee-for-service as much as we could get it. And what we do there is use a model that looks at the panel that a primary care attributes and the risk of that panel using those claims data to come up with a population-based payment. So we're paying the primary care office based on the specific patients they care for and not so much on the number of office visits that they can churn. And that's been a pretty exciting program to date. We've grown the number of participants, and I continue to have a lot of fun working with that program. All right, so thus far I've spoken about what an ACO is, a little bit about OneCare Vermont and how we're structured and what our role is with our providers. And this slide is intended to help show how we fit into the Vermont all-payer model. So again, Ina gave a nice overview in total of what that Vermont all-payer model agreement is. But just say it again, agreement between Vermont and CMS or Medicare. There's a lot of ways you can look at it. I'll give my perception of it, and it's not the only relevant perception, but I view the Vermont all-payer model as an agreement in place to incentivize and expand ACO and value-based care healthcare models across Vermont. By having scale targets for the state, what it says to me is that we as a state would like to see more value-based arrangements that reward providers for effective, high-quality healthcare. And the way that that works for OneCare is that when we enter into a program agreement with a payer, the lives that the ACO or OneCare ends up being responsible for, or accountable for, can count towards those scale target goals. There are a couple of requirements in place to make sure that the program design is in spirit of what the all-payer model is calling for. But if that program is in the spirit, then those lives count towards scale. Where we are today is that since the beginning of the all-payer model, we've really developed a vast statewide network. You can see the map to the left. The only community that hasn't signed up for any programs is Townsend. That's where the Grace Cottage Hospital resides, a relatively small community, but one we speak with regularly. Where we still have opportunity is in program participation. So the most widespread program we facilitate is the Medicaid program. And in my view, we have a very vast network across the state. When we look at programs like Medicare, for example, we don't have everybody participating yet. And there's a couple of reasons for that. Some of it is the program design. Some of it is the magnitude of financial accountability that comes with it. And while it's a great concept to say, we want to be accountable, and if we deliver great healthcare, we want to be rewarded for that financially. And if we don't, there'll be some sort of a penalty. The size of that penalty can be scary, especially if you're a smaller rural hospital, and to consider at the end of the year needing to potentially write a significant check back to OneCare that ends up going to Medicare. So we call that risk in our world. And essentially in the Medicare program, the magnitude of the risk is significant. And I think, in my view, has been a deterrent to broader participation in the program. We really worked hard in 2020 in response to COVID, but I don't think it's solely in response to COVID, but tried to work with Medicare and Agreement and Care Board to narrow the risk magnitude, so shrink it, so that the providers wouldn't be potentially subject to a scary payment at the end of the program year. And then this slide highlights how all of this comes together. And under the all-payer model, there are a number of different players. And really the key is that this needs to be, in my view, a partnership where the state, the commercial and public payers, the federal government, and the accountable care organizations such as OneCare are all working together towards shared goals. And that's an important aspect to me. Without it, I think we risk continuing down a fractured path where we're all working towards our own objectives and ideals. And I think for Vermont to really succeed in achieving the level of scale as called for in the all-payer model agreement, and getting the providers to really buy into the concept of value-based care, we all need to be working together effectively and, like I said, sharing the same vision. So closing up on the standard presentation part here, this is a quote from Claudio Fort, who's the president and CEO of Rutland Regional Medical Center. I really like this one, but he's basically saying, to paraphrase, that pandemic was really a proof of concept, in my view, that fee-for-service is unsustainable. And really moving to this value-based healthcare paradigm, which includes payment reform, includes accountability for quality, enhances collaboration, utilizes data more effectively, is really an important path forward. And it was really exciting that in 2021, the Rutland Hospital and the community and the FQHC there are moving into the Medicare program, which is a great growth area because there's just a lot of lives in that community. So I'm glad to see Rutland signing up for that program in 2021. I've included a couple other appendices here, just a few stats about the number of lives that we have, provider types participating. and then quality measures here, so you can see what they are. They look detailed. One of our goals in the quality measures is to make sure we have the right measures, but also align them between programs from a provider standpoint. I'm certain it can feel daunting to have all these different payers, all these different quality measures. So we've really tried to make sure these are aligned as much as possible and focus on the right areas. So that is what I had for the high level overview. I'm happy to entertain questions, go back to any slides, go deeper on any topics you like.
Tom, thank you. Just as a general comment, for those of us who have had presentations from you folks in the past, this is very clear, and I think it explains the ACO at a level that people can get into it. So I appreciate that. It's an excellent opportunity for us to understand what you folks are about.
Great,
So,
thank you.
So thank you, and thank Vicky as well. I know she couldn't be here, and I know she's busy with other things, but we do appreciate the effort that OneCare has taken to build this educational PowerPoint. So, questions committee? No questions? Oh. Oh, there they are. There they are. I couldn't see you. All right. So we'll start. I think we'll start with Senator Hooker, and then we'll go to Senator Hardy.
Thank you. Thank you, Tom. This is complicated, as we usually say in healthcare, but I'm curious to know, are all Vermonters eligible to be part of the ACO?
Yes. I mean, effectively, any Vermonter can be attributed to an ACO as long as but it depends on their coverage, essentially. So if it's with a payer like Medicaid and Medicare, as long as their primary care relationship is with a OneCare provider, they will be attributed. I think the nuance that's important to note is that some Vermonters have coverage through commercial insurers that may be domiciled out of the state. It could be a national level insurer. And yes, OneCare can enter into an agreement with that call it non-Vermont insurer. That's hard to do, especially trying to get a program that's aligned with our goals in Vermont. We've had a number of discussions with those national level payers, and they typically have very canned ACO models that are standard. This is what they offer to any ACO in the country. So technically the answer is yes, but that's probably the biggest nuance is when you have out-of-state insurers for Vermonters in general.
Okay, and one other, if I may. You talked about I think we all know that primary care physicians are very important, integral to any program that we're going to do. How many of the primary care physicians are enrolled in ACO at the moment after 3 years?
I don't have the number at the top of my head. We can follow up with the exact number, but I'll risk taking a guess because I think I'm pretty close, but I want to say there's about 130 primary care sites across the state. And then most of those sites have more than one. Some are sole practices, but most will have more than one. We can certainly get that information for you. That will be and when we quote that participation level, it's essentially in the biggest program, which is Medicaid, because in one way or another, they're participating with OneCare Vermont. In which programs they elect to join is kind of a second layer underneath.
Some of the who's in and who's out really does depend on whether it's a Medicaid, Medicare provider. And then your negotiations with, say, Blue Cross and Blue Shield or other private insurers also helps to bring in providers and patients. It's another complex process. can you just, and I know that Senator Hardy has a question, but how many attributable lives are there now in the system for you in One Care?
In 2021's budget, we anticipated about 288, I think, thousand total attributed lives,
Yeah.
which when I started with One Care in 2017, there were 29,000. So it's
Right.
pretty aggressive growth in my particular view of the world. And I think there's a couple ways to look at scale that this might be important to note too, that there's statewide scale, and that's what the all-payer model really is calling for, to see the state of Vermont achieve these scale targets at that macro level. A layer down is community level scale or hospital or health service area level scale. Communities that are participating in all programs, I'd argue, have a pretty high percentage of their patients attributed. And maybe it's 60, 70% of their lives attributed to one program or another. And within that community, that's pretty good.
Yeah.
Overall. And then there are other communities that may participate in only the Medicaid program, for example, and then that percentage goes down further because their Medicare patients or their commercial patients are not included. So that community level perspective is important too. And then one layer down, because again, I agree, everything's complicated, is the provider level. And a provider that participates in all the programs has that same may have that same experience where a pretty good percentage of their patients are attributed, and therefore we have access to the data and can get incentive payments for population health efforts. But a practice participating in one program will have a smaller percentage. So I hear it both ways from providers. I think there's a lot of providers who really want within their practice to see a high percentage. Some really prioritize the community level. But it's important to have that perspective too in terms of actual care delivery.
Okay. Senator Hardy, you have a question.
Yeah, thank you. I have a series of related questions for you. Tom, thank you for your presentation. One Care is a private for-profit organization, is that correct?
That is correct.
Okay, so one of the criticisms that I've heard of One Care is that because it is a for-profit entity, it has incentive for, getting money out of the system for its own sort of profit motive as a private profit organization. And it also is, because it's not subject to public open meetings and public records, it often it has the appearance of not being very transparent with its information and its meetings. So I'm wondering if you could speak to that criticism that I think we probably have all heard, and what your perspective is on that.
And
Sure.
just as you're answering that, just know that this committee has taken testimony about the nonprofit profit issue, and we can get Jen Carby in to talk about it again. But both of your questions are very important.
Yeah, happy to speak to it. It's a little bit of a technical answer, so apologize for getting a little bit detailed here, but there is a conflict between Vermont nonprofit law and federal ACO requirements. To be an ACO participating in a Medicare program, 75% of your board members need to be participants in your ACO model. And when a board member is a participant on the board, that therefore means they are financially interested in the activities of the ACO. Vermont nonprofit law, however, requires that no more than 50% of your board members can be financially interested in the organization. So there's a conflict between being a Medicare ACO in a Medicare ACO program and being a Vermont nonprofit. We have, in response to the feedback we've heard, applied for a 501c3 status with the federal government. That application has been submitted, but no response yet. I expect it will take some time. And even with that, I think what's important, and these are just words, but we do operate as a nonprofit. we are a network of providers that are trying to make this transition to value-based care work and effective. And if OneCare Vermont is perceived by its participants to be, I'll just say it bluntly, siphoning off money from the healthcare system, I don't think that's a strategy for long-term success. So when we are managing OneCare finances with our participants, it's all in spirit of how do we make this work long-term, balancing the cost that the participants pay in to help make this work. And the only years in which we've had a positive operating margin are years when we've been required to do so by the Green Mountain Care Board to build reserves. And the reserves are really earmarked for the event that maybe a participant owes some money to us at the end of the year to pay back Medicare, to make sure we have some financial reserves to protect the solvency of OneCare. So does that help answer your question?
Yes, that is very helpful. Thank you. And I said I have a couple of questions. So my next question is about the providers that participate in OneCare and whether or not they have to pay fees to be part of OneCare. And if so, besides the payer reform, which I understand, what do they get from, if they do have to pay fees, what do they get back as a service for the payment of those fees to OneCare?
Sure, good question too. So the hospitals pay what we call dues or participation fees. You might hear both terms. And one of the realities of this kind of transition is that it takes work and takes effort. So it's therefore not free. So what the model that we've built relies on the hospitals to, the way I think of it is pre-invest in OneCare. We use those investments not only to build out our care coordination program, for example, or build our data infrastructure that hopefully has direct benefit to the hospitals, but also invest in independent primary care or designated agencies. And the idea is that if those investments are successful, we will earn shared savings that can offset those pre-investments the hospitals made. In that model, performance is very important. We need to ensure that we have good results to make this sustainable so that the investments that hospitals make can reasonably, and we're not going to earn shared savings every single year, but we'll be able to get some of that money back through shared savings and make the model work over time. What we experienced since the beginning was as we ramped up aggressively, the hospital dues and the costs placed on the hospitals grew tremendously. And in my view, they were significantly too high back in 2019 in particular. Over the last 2 fiscal years, and particularly with COVID, we've made a lot of efforts to reduce those hospital costs, upfront costs, just in response to their financial circumstances and in spirit of making this model sustainable. It was unsustainable to charge hospitals the amount that was charged in that 2019 period. So that's tricky to do. I mean, when you take out those resources that are coming into OneCare, we have to narrow our focus too. I mean, some of the programs that we really enjoyed in 2019 had to be skinny down, and we're really trying to focus on the core activities and the core areas that will help us succeed long term, and balance some of the goals that are in, for example, the state's improvement plan with what we can really do as well. So it's a challenging space, but absolutely the hospital dues are something that we pay attention to very closely to make sure that they are not overly burdensome on participants.
Okay, that's helpful. I've heard that criticism about the dues from independent, smaller practices, not just from hospitals. And when I've asked practices, do you participate in OneCare, and if not, why? One of the answers I get frequently is it's too expensive, and we don't get enough back in return. So I think there's a perception that the services for each individual practice are not sufficient to justify the cost for the participation, especially for smaller providers. So just
That's
that's
helpful to hear.
a common thing I hear.
So, and then, I want to add a comment here, because I think what we're seeing is the tension that exists as this whole process is put in place, remembering that one of the big benefits is improvement of population health. And how does that happen? It happens by informing clinical practice within those individual practices. But that all takes time. And so you can't do that unless you have enough patients and enough practices. So it's a vicious circle if it doesn't move in the right direction. But so anyway. Any other questions? Ruth, did you have another question?
I think that's it for now.
Okay.
I always have more questions, but I'll hold off. I see that Senator Hooker had her hand up again, so thank you.
Yeah, just to follow up on the whole either pre-investment or whatever, you mentioned, Tom, kind of scary penalties. Does that intersect with the idea of the prepayment and not being able to get sort of reimbursed? Is that what you were referring to?
So that risk term that you hear is really something that occurs at the end of the year. So it's separate from the ordinary provider reimbursements, either as a fixed lump sum payment or just the regular fee-for-service payments. What happens at the end of the year, after the program is over, there's what we call a settlement process where the payer basically does a calculation of all the healthcare costs that they had to pay relative to that prearranged amount that was agreed upon. And depending on the result, it's either a payment to the ACO from the payer or from the ACO to the payer. Now, that happens in aggregate. That's at the OneCare level. The invoice comes to OneCare Vermont. We have to write the check. What we needed to do, and still need to do, is have a model to determine who within the OneCare network contributes to that. Either way, whether it's going out or in either direction. And that's certainly challenging. What we've done in the early onset of programs is rely on the hospitals under this model of they're making a pre-investment. Let's give them the opportunity through shared savings to earn that investment back and make this balance. But we have relied heavily on the hospitals to contribute to any downside payment that would be owed back to a payer in order to avoid having to charge in small independent primary care, home health agencies, et cetera, because I think that would have been a real deterrent to broader participation early on.
I do have one more comment, and that's just I'm surprised to hear that there are problems or challenges with getting Medicare providers to participate, especially given what we just heard from Ina Backus about how Medicare was part of this whole agreement from the beginning. And I guess it's just a comment. I'm surprised at that, and I'm curious about how that can be improved, because it seems like that should be a low-hanging fruit given that it's a federal program and the feds have agreed to all of this, and yet they're not participating at the level we sort of need them to be to make this successful.
Yeah, I have a couple of thoughts. The first is I spoke a little bit about the magnitude of risk, and prior to the adjustments that we made from COVID, there was a 5% band essentially. So either you'd get an extra 5% bonus or you would owe a 5% kind of a penalty, I'll call it shared losses. And a Medicare person covered life beneficiary, their healthcare costs are roughly 2.5 times a Medicaid person and maybe double a Blue Cross person. So when you take just the magnitude of the healthcare costs and you look at that statewide, we have something like $600 million of spend in the Medicare program. The downside risk payment is significant. So one of the strategies was let's move from a 5%, which is the low number for most Medicare programs, and skinny that down. So we moved to a 2% risk corridor in 2021, which I think is really helpful. So that's one issue that I think we're trying to address. The second issue, and this relates a lot to hospitals, is Medicare does offer a fixed payment model to us, but it doesn't work like Medicaid. Medicaid gives us a fixed payment, and that's it. That's the payment you get for dealing with your patients in the hospital setting. If they deliver more care than that payment was worth, sorry, that was the budget. And if it's less, congratulations, you did a really good job managing your hospital spending, and it's a benefit of this particular program, but really putting those hospitals on a budget, so to speak. Medicare reconciles the fixed payment. And what they do at the end of the year is they compare, here's what the fixed payment was to the fee-for-service equivalent value of all the claims that were billed. And that is a reconciling item at the end of the program. It can go either direction. It can be money coming to the ACO or from. But I think on the spectrum of payment reform, it's not as far along as the Medicaid program. So we have been advocating with our state partners at AHS, as well as the Green Mountain Care Board. Let's try to convert the Medicare fixed payment to this true payment reform. I think that's a much more attractive model to the hospitals. And I would hope if we can achieve that goal, we see other hospitals and communities start to participate in that program.
Great, thanks. That's helpful.
You're welcome.
Very good. Thank you. I'm sure we'll be back looking at the ACO organization again. I know that as Senator Hardy has said, and others of us have heard, there have been significant complaints rendered against the organization. And, I think it's important to understand what you folks are doing, and then what it promises or doesn't promise for healthcare reform in the state, and keep an eye on things. But I have to say, from a personal point of view, that the transparency of the organization has always been there. So we do appreciate that.
Thank you.
All right. So thank you, Tom. And what we'll do is I'd just like to take a 2-minute break. And so come back at 11:35, please. And Nellie, you can put the little flag up, and we will be back in 2 minutes.
Thank you.
Are we here? All right. We have a quorum. That's good. Okay, this has been a really full and rich day of testimony, and it'll take some time to process it all. I appreciate that. But I think we do have a number of bills, and this half hour I had put in simply to have a look at the bills that are in committee, and then to pick those that may have some relationship to COVID and the pandemic. So I think what we'll do is, and this is like a 20,000 foot level review, and see that David Hall and Katie are both here. So David, why don't we begin with you? And this is a thank you for being here, first of all, and then it's good to see you. And then let's do the 50,000 foot. This is a bill that we passed over to the House last year.
Sure. Good morning, David Hall, Legislative Counsel. I am here on S28. So I'm one of your attorneys. I staff Commerce and Economic Development, and that includes consumer protection. And that's the real nature of this bill, S28, which really simple in a nutshell, it adds to the list of products that cannot be manufactured or sold in Vermont what's called a baby bumper pad. And so this bill is 3 pages long, and if I'm not sharing it right now, but I can tell you quickly that the baby bumper pad defined in the children's product safety subchapter to mean a pad of non-mesh material that rests directly above the mattress in a crib or runs around the crib. It's intended to be used until the child or infant pulls to stand. Again, it goes on the list of children's products that can't be manufactured or sold in the state. It makes it a consumer protection violation to do so. And that's enforceable by the AG's office or the state's attorney. That's really it.
Okay. That's it. Questions for David? Okay, we're good.
All right.
Thank you. Thanks
Sure.
for coming in.
Glad to be here.
And so Katie, you have a lot of bills here.
I have the next two bills. I have
Okay.
S19 and S20, and then Jen will be right over. So
Okay.
both of these bills, I believe, passed out of the Senate last year. I'm certain that the PFAS bill did, S20, and I'm trying to recollect if
Yes, it did.
S19 just got out of committee or out of the Senate.
It went over to the House.
Great. Okay. So a high level overview of what S19 does. It really does two things. First, it requires the Department of Health, along with the Chief Prevention Officer, to develop and adopt a statewide climate change response plan. And the plan specifically looks at things like the type of populations that the plan should protect, including infants, young children, elders, persons with disabilities, persons who primarily work outdoors, persons with low income, or persons who are homeless. And it goes on to require an actionable list of strategies for both rural and urban communities. And a second piece of this climate response change is looking at the communication between the health department and regional planning commissions and regional emergency planning providers in coordinating a response to climate change and the effects of climate change. So that's kind of part one of the bill. And this second part of the bill requires that regional planning commissions assist in the identification of climate change related risks. And specifically, there's language added to the duties of the regional planning commissions that they're to consult with and assist hospitals regarding the development of a health needs assessment and initiatives as needed, and also to consult with and assist the Agency of Human Services, Department of Health, Vermont Emergency Management, to incorporate public health and safety concerns related to climate change into state and local emergency hazard mitigation response and recovery plans. So those are the two pieces of S19.
Okay, and we'll get the Department of Health in because they've been working on this regardless, as well as our regional planning commissions. Okay,
Okay, I'll move along to S20, and this is related to restrictions on perfluoroalkyl and polyfluoroalkyl substances and other chemicals of concern in consumer projects, otherwise known as PFAS. This is the PFAS bill. So this bill is similar, very similar to the one that passed out of the Senate last year, and there have been a few additions to this iteration. So there are a lot of different sections of the bill. So maybe I'll just kind of walk you through high level the different types of things that this bill does. First, in the first kind of section or groups of sections, it imposes restrictions on the use, manufacture, sale, and distribution of Class B firefighting foam that contain PFAS. The second part of the bill imposes restrictions on the manufacture, sale, and distribution of food packaging with either PFAS, phthalates, or bisphenols. The third part of the bill imposes restrictions on the manufacture, sale, and distribution of residential rugs, carpets, and aftermarket stain and water resistance treatments to which PFAS have been added, and that is a new addition, language about the aftermarket stain and water resistance treatments. So that's new this year. The next section is also new this year, that imposes restrictions on the manufacture, sale, and distribution of ski wax. And the last few sections of the bill are the same from the version that passed out of the Senate last year. That's to include PFAS on the list of chemicals of high concern to children. So that was a very high
okay.
level.
That was super high, but that was perfect. I think it gave people a flavor for what's in the bill. Not that we want to be consuming PFAS, but okay. So that's it. Questions for Katie on either of those? Okay. And we'll come back and have a committee discussion on the bills that we're going to be taking up. So thank you, Katie. I keep muting myself in the middle of a sentence. I'm sorry. Jen Carby is here and she is ready to give us the 60,000 foot overview of two other bills. So go ahead.
All right, so I'm going to be talking to you about S22 and S23. S22 is sponsored by the chair. Actually, they're both sponsored by the chair. And the very high level of this one is that it deals with healthcare practitioners who administer stem cell products that are not approved by the U.S. Food and Drug Administration, the FDA, requires them to provide notice to their patients of the fact that the product is not FDA approved, to provide that notice to their patients in their advertisements, and then give a disclosure form to the patient each time they administer one of these products. There are some definitions. This is based on the version that passed out of Senate Health and Welfare last year. It then sat on the Senate calendar for a number of months while various other things are happening, and was eventually taken back in by the committee. So referred back to the committee. So it gives specifics on what that notice has to look like, including some font requirements and requirements for what has to be in the advertisement, both radio and print, and then gives some exemptions for both healthcare practitioners who have gotten approval or clearance for an investigational new drug or device from the FDA for the use of stem cell products, or someone who is administering this product under an employment or other contract with certain national organizations that are listed in the bill.
And so as Jen said, I think this was a result of COVID. It sort of sat for a long period of time.
Right.
And then we pulled it off the calendar. I think it wasn't until August or September. I forgot.
It was right at the end of the session. I think it was
Yeah,
in
it was right
September.
at the end.
'Cause I kept waiting for it to come up.
And then, oh, I'm sorry.
No, that's okay.
So, and the other, just as an aside comment, I have read a couple of articles and seen some information that there have been some purported not unapproved FDA therapies using stem cells that have been sort of suggested that they're effective against COVID, and no, without I think without data. So I don't know what that means for us, but just of interest. Go ahead, Ruth.
I'm just curious. I mean, you mentioned one just now, but I'm curious what these products are and like sort of what.
Don't
what
ask
is
that
the,
now.
Okay, all right.
That's a good question, and that's an excellent question. So we'll, if and when we get our, we probably will take testimony on it. The testimony will help clarify
Okay.
exactly what this is.
I'm just trying to get a sense of the urgency or the sort of
We'll get
how
it.
widespread nature it is or
Oh,
not.
yeah.
I don't know.
Well,
So,
and so I will say
not
that some
familiar
of the testimony that we had last session was quite heated until the language was improved. So there was significant controversy. Senator Cummings, you're muted, Senator.
We're missing, last year when we were working on this bill, the Times Argus, every day, several times a week, had a full page ad. It usually started with a disease. And if you have this condition, come down, and I think it was to the local hotel, like where you go to buy Oriental rugs.
Yes.
And learn about this treatment
Miracle.
that could cure your disease. So it was kind of, at least for me, right there in front of me every morning in my newspaper. And it was a different disease every day or weekly, and just a continuing series of full page ads, only offset by the vaping ads, which were also full page.
The committee did hear testimony as well from the Attorney General's office, their Consumer Protection Division, about some specific incidents that had occurred in Vermont. So if you take testimony, you may want to hear from them.
Yes, you're right. We will. We'll get that. Thank you. Senator Hooker.
Just a comment that last year I remember talking to you, Senator Lyons, about this because one of my constituents had been a victim, I'd say, of the treatment, and it costs thousands of dollars, not covered by insurance.
Right. It's not FDA approved, it's not covered. So it makes it, for some people, it may appear to be a last resort when you think, and I think that's what Senator Cummings was talking about. All right.
Right. You want to move on to S23? S23, as I mentioned, is also sponsored by the chair of the committee. This is an act requiring relating to requiring that at least one member of the Green Mountain Care Board be a healthcare professional. Pretty much says it all. This is the version that was passed out of the Senate last year. So it requires at least one member of the Green Mountain Care Board to be a licensed physician, physician assistant, naturopathic physician, or registered nurse or advanced practice registered nurse. And it specifies, as far as the effective date, it would take effect on passage, but it would apply beginning with the first vacancy on the board, unless somebody who is a non-healthcare professional wanted to continue serving. They could still be reappointed. So it wouldn't prevent somebody from being reappointed who is not a provider, but it would prohibit a new person from being appointed who wasn't a provider if there wasn't already a provider on.
Sorry. Senator Terenzini.
Thank you, Senator Lyons. Just a question. Is there currently not a medical expert as one of the board members?
That's right.
That's correct.
Doesn't seem to make a lot of sense to me.
There are certain requirements for members of the board, but one of those requirements is not that the person be a provider. There's requirements and expertise or experience in healthcare or health economics, that kind of stuff, but not specifically. There have been providers on in the past, but not consistently.
And you know, one of the interesting things about the Green Mountain Care Board is that it was formulated under a single payer legislation. And so then the question is, does the board meet its requirements with the new direction our healthcare reform is taking? So there are a lot of questions about the board, not just its membership, but when you do start to look at the membership, it is complicated, because then the question is, how do you implement this without kicking someone off, and a lot of other things. So I just think it's worth a conversation. In the past, we did have a nurse, a PhD, a nursing professor from UVM was on the board. We had a primary care doc on the board, and now we don't have that on the board. And given where we are with quality metrics and clinical assessment as part of reform, it seems really appropriate to have someone who understands clinical practice in some way. So, Senator Hooker.
Senator Lyons, how long are the terms on that board?
6 years, right, Jen?
That's right.
Thank you.
Yeah. And then, and that's the other question is the board, are there too many members on the board, or, what's an optimal number of members on the board? Some people have said 3, it's currently 5. It could be 100, who knows? Not 100. Questions for Jen? Okay, so that was the 60,000 foot level. Obviously, there's testimony to be taken as we go forward with one or more of these bills. I'm interested in what the other bills that will be coming in to our committee. I know that Senator Terenzini and I have asked to have a bill drafted on an ALS, commonly called Lou Gehrig's disease, an ALS registry. And I'm going to be sharing that with the rest of you on the committee and see if you'd like to sponsor. And I know that members of the Education Committee are interested in sponsoring, so it'll be an interesting group of folks when we get there. So that bill will be coming in, and I know that I think that the Nurse Compact bill should be coming to us very soon. I'm hoping that we'll see it. It was drafted by Betsy Rask's replacement, who is ordinarily at GovOps, so we'll see where it goes. And I don't know what else will be coming to us. I have a draft request in. I should share this with you on some healthcare reform pieces, but I'm sort of holding off on that until we as a committee can have a discussion and see the things that we would like to work on. And then we have our little bill on the emergency plan for pandemic healthcare. So, okay. Anything else? Thank you all. Yes, Senator Hooker.
Today is Homelessness Awareness Day. And I was reading one of my homework assignments last night on homelessness, and fortunately we did a pretty good job of protecting homeless people, homeless individuals throughout the pandemic. The unfortunate thing is that we're still having to protect homeless individuals throughout the pandemic, and there's a real need for more permanent housing for people throughout the state, which we already know. But.
Yes, and actually, and we did do a good job, but you're right, it didn't solve the problem. Thank you. Thank you for reminding us of that. Anything else? Trying to stay within our tradition, and we have done it. So we are a little early. Your work today, I know you've been very much engaged and greatly appreciate that. It's not easy going through all of this, but we have an awesome committee, so we're great. Okay, so I will see you tomorrow morning at 9 o'clock, and thank you all, and take care.